Good morning or afternoon, everyone. This is Mrs. Franson, and I am recording this lecture for you today. We're covering Chapter 2, the relevant theories and therapies for nursing practice. The goal of this lecture is to help you understand the basics of why we do the things as far as treatment of patients that are mentally ill. So we're going to be reviewing some of the psychological theories that help us to understand behavior, and we're going to relate those theories to the psychological therapies that we use as treatment because they're based on the theories. We're only going to do selected psychoanalytic theories today because we're not going to spend a lot of time in this chapter since you've already had 2 psychology courses. First of all, let's refer back to Freud and remember that Freud developed the psychoanalytic theory, and he took the personality apart into different sections, and he taught us about the id, the ego, and the superego. Since you've covered this in your psychology classes, I'm going to let you review that on your own. We know that because of Freud's psychoanalytic theory, um, we understand defense mechanisms and how people cope with high levels of anxiety. We know that defense mechanisms almost completely operate on the unconscious level, and all of us use defense mechanisms to deny, falsify, or to distort reality to make it less threatening. Defense mechanisms are neither good nor bad. How we use them can be healthy and unhealthy. Your mind uses defense mechanisms to ward off anxiety by preventing conscious awareness of threatening feelings. Defense mechanisms share 2 common features, except for suppression. They operate on the unconscious level, and we use them to deny, falsify, and distort reality, all to make it less threatening. I'm going to refer you again to page 283. This is a very important page that we need to know. Now let's use a nursing student, for example. The nursing student wants to be successful in nursing school, and our nursing student understands that if he does not pass his exams, he won't be successful. So in his mind, he believes that he cannot fail because he stayed up all night and studied. But he did fail. So what really happened? Perhaps his perception of reality has been altered due to a high level of anxiety. Perhaps he had not studied the material at all, and he was going to try to cram the night before. This doesn't work when you're using application level questions. You have to really know and understand the material. Perhaps he's using something else. Maybe he's using denial. Maybe he knows he accidentally went to sleep at 10 o'clock and slept the whole night instead of staying up and studying. Perhaps he used something else, which we call another type of defense mechanism called reaction formation. Deep down inside, what he really wants out of life is to graduate from nursing school. But he's going to use reaction formation as a defense mechanism. He's going to adopt and foster the opposite of how he really feels. So instead of saying, I really want to graduate from nursing school and I did not study enough for my exam, he'll use reaction formation, and instead he'll say, this is a sorry nursing school. I wouldn't go here if you paid me $1,000. It's not my fault I didn't know the material. It's those stupid instructors. They didn't teach me. They didn't provide me with what I needed. That's an example of reaction formation and how it works. Now let's use a case study to illustrate another defense mechanism. A patient's admitted to your unit who has an uncanny resemblance to your older sister. As a child, your older sister bossed you around and criticized you constantly. You started looking at the patient and thinking, this woman is horribly critical. All she wants to do is criticize me and dictate to me what I need to do. Then you realize that you're responding negatively to this patient. So you ask yourself, what is really going on here? After some self-reflection, you may realize the person looks like your sister and you're using transference or countertransference in this case to give characteristics to the patient that are not really the patient's characteristics. Now, when a patient transfers negative feelings to a care provider, that's called transference. When a care provider transfers characteristics to a patient that are not really there, that's called countertransference. And you can read about this particular mechanism on page 283 and also in your chapter. Another theorist that really does play an important foundation in the understanding of our mental health patients is Erickson. If you'll remember from your psychology courses, Erickson divided all of life into 5 categories. And he stated that in each of these categories, we have a very important task that we need to channel our emotional energy toward accomplishing. And if something bad happens to the individual while they are in this stage and that energy gets channeled in another direction, then they will not accomplish that goal. And that's why we have the names of these categories like you see. And I'm going to use, for example, identity versus role confusion, what goes on between the ages of 12 and 20. So we know that during adolescence, the number one goal, psychic goal during adolescence, is for the adolescent to develop a sense of identity. If something happens to disrupt this process, they end up with role confusion. So let's use as an example a 13-year-old girl who becomes accidentally pregnant. Now, we all understand that a 13-year-old is not in a position to have the maturity to parent. So this is a catastrophic event for this teenage girl. She becomes pregnant, she has a baby, she becomes a mother at the age of 13. So she's just starting out to develop her identity. Now she doesn't have that psychic energy available to develop her identity. It must go to emergency parenting and all the different emotional adjustments that come with her situation. So for the rest of her life, she will have a weakened identity and she will struggle with role confusion. Another example is industry versus inferiority. The school-age child between the ages of 6 and 12. This child's number one task is to accomplish something through industry to develop his sense of self-worth. So if something diverts his psychic energy from completing something through industry, he will have lower self-esteem. Let me give you an example. Let's talk about the 8-year-old child who loves his father, idolizes his father, but his father gets arrested for drugs and gets sent to prison. So at the age of 8, for all practical purposes, he has lost his father because his father is no longer available to him. So he will grieve, he will anguish, he will have anger, and all of these emotions associated with this event will pull his psychological energy away from industry, from learning to throw a baseball, from learning to do his timetables, from all the different industry tasks that children do. And because he is not accomplishing in the rate and manner that he needs to, he will not develop a strong sense of self-esteem. And he will leave this period of his life with lower self-esteem than he should have, and he may struggle with that for the rest of his life. Erickson believed that an individual's development is influenced by their family relationships, by their culture, and by their society, and that the development continues throughout the lifespan. Now, when you're in the clinical environment, you need to look at your patients, get to know your patients, and see if you can identify one of Erickson's stages where their development was disrupted. And you will see through this the foundation of their current issues. Remember that the developmental model is part of your nursing assessment, and it's also going to help you to determine what interventions are going to most likely be effective for the patient. If the patient is troubled over their identity, then you may do interventions that will help them explore their identity. If they're troubled with poor self-esteem, then you may do things like activities to help them increase self-esteem, increase self-understanding. Those would be good for that kind of patient. Now, Sullivan did a lot of research that was based on the belief that psychiatric disorders are influenced by our relationships and by our social interactions. So the goal of this type of therapy is to improve interpersonal functioning and satisfaction with social relationships. Sullivan's theories are often used for short-term treatment, and they're very effective when working with people that are depressed, that are going through grief, and are socially isolated. We know that the purpose of all behavior is to get our needs met, and that our personal interactions, our interpersonal relationships are critical to our happiness. We're going to talk briefly about some theories that you've probably read about in psychology. I'm just going to remind you that Pavlov did the original research on conditioning and how the subconscious plays in all of our lives. Watson introduced behaviorism, and he believed that anyone can be trained to do anything. One of the things that Watson teaches us is that personalities are not carved in stone at an early age. Personality simply consists of learned behaviors, and for this reason, behavior and therefore personality can be changed. We know that behavioral responses are learned and can be modified, and this is where Skinner comes in. Skinner developed operant conditioning theory, and he taught us that voluntary behaviors can be learned, and that both positive and negative reinforcement can be effective in changing behavior. Conditioning pairs with behavior that either reinforces or diminishes the behavior. Now, modeling is something that you're going to be doing in clinical. Patients learn through imitation, and they'll be watching every single thing we do and learning from us in the clinical environment. Operant conditioning refers to the fact that behavior modification can be accomplished with rewards. Systematic desensitization is where we very systematically, carefully, and safely expose a patient to something that they are afraid of, to help them to desensitize to that as a stimulant and learn to overcome their fear of that particular thing. Aversion therapy is used in a limited way. Like recovering alcoholics may take a drug that would make them physically sick if they drink. Another example is people who have sexual deviance issues, like sexual predators, child predators. We can give them a drug that will suppress their libido and help them to have more control over their behavior. So that's another example. Cognitive therapy refers to therapy that's based on the idea that the individual is dynamic, the environment is dynamic, always changing, and so individuals and their environment are always interacting. Uh, Cognitive therapy teaches us that thoughts come before feelings and actions. So we can change feelings and thoughts, and then we can change action. Thoughts about the world and our place in it are based on our own unique perspective, and that perspective may or may not be based on reality. And for this reason, cognitive therapy can help us change thoughts that may not be in our best interest. And once we change thoughts, we can change feelings, and then we can change behaviors. Rational emotive behavioral therapy helps us to eradicate irrational beliefs and to recognize thoughts that are not based on reality and are not accurate. Cognitive behavioral therapy helps us to test distorted beliefs and change our way of thinking so that our symptoms can be reduced. Helping people identify and change negative thought patterns is a very important and worthwhile intervention, and it's something that we can do as students in the clinical environment. I want to remind you about Maslow's hierarchy of needs. Remember that human beings are active participants in life, and all of us are striving for self-actualization, which just means we want to be the best people that we can be in every way. We want to lead happy, full, satisfying lives. But sometimes people go about obtaining those goals in self-destructive ways. I also want to remind you before you start working with your patients that lower needs must be met before people can address higher needs. We want to emphasize the human potential and patients' strengths, and we want to use Maslow to prioritize our nursing actions. So let's look one more time at Maslow's hierarchy. And for example, if you have a patient that feels unsafe, if you look on this hierarchy, you'll see that it's on the second level. It's very low to the bottom. So I doubt you're going to have success talking about your patient's feelings if they're in an environment where they feel like they may get punched in the face within the next few minutes. So keep in mind that lower needs must always be met before higher needs. Now, our biological theories are basically the scientific foundation for the medications that we give. We basically want to understand our meds and know that we have many different reasons for mental illness. Some of them are physical, organic changes to the brain, where neurological and biological damage is done. Sometimes the damage is genetic, sometimes it's chemical, as in the case of substance abuse, or depression. So the way we use our biological interventions, which are our medications for the most part, with the brain are based on these biological theories. Now, NLU just means the use of total environment. And when we get to the hospital, everything about the environment of the hospital is carefully thought out, and the people, the setting, the structure, and the emotional climate is designed to help the patient to get better. Just a structured day can be very important to some of the patients. We take these things for granted because we structure our own day and we meet our own needs. But people that are mentally ill are not able to do that, so that is an important therapy that we're going to participate in the clinical environment. I hope this recorded lecture has helped you to prepare for the exam 1, and I will see you soon. Bye-bye.